My name is Monica Jones. I'm the founder of the Pediatric Epilepsy Surgery Alliance, and we're very happy to be able to introduce today two wonderful speakers. Dr. Saleem Malik is the medical director at Cook's Children's Hospital. He's also the director of their MEG program. And Kate Cooper is a parent in our community. Her daughter has had epilepsy surgery, and she really found a lot of answers with MEG imaging, and that will be the topic today, about improving surgical outcomes using MEG. Thank you.
Thanks, Monica. We're going to be talking about better surgical outcomes using MEG, and we're going to do this through the story of my daughter's surgery. We're going to present this as a case study, talk about her specifically, but just ask that you keep in mind, this is of course just one person's story, and I'll be speaking really specifically to that, and then Dr. Malik will speak more generally about MEG. We're going to leave plenty of time for questions at the end, and if we don't have enough, even then, please come and find us individually, come to the Megan table. We're happy to talk to you. So there are really three lessons, we believe, in Virginia's case study. The first is that the recent advances in the pre-surgical evaluations mean that more people are candidates for epilepsy surgery. Recent advances in the surgery itself mean that the recovery from surgery is simple, the surgery is less invasive, those two go hand in hand. And then finally, that epilepsy surgery is really underutilized in the United States. So those are three things we want you all to keep in mind as we go through this study.
So before we move on, just to explain, this is a very nice and very up-to-date description of epilepsy surgery. What is an epilepsy surgery? I think the important take-home message is epilepsy surgery is an elective surgery. Most of the time, it is not, and 99% of the time, it is not an urgent thing to be done. It has to be planned, and it can be done at a certain time when the patient, family, and the doctor or surgeons are ready to do it. It can involve either resection of small part of the brain or a bigger part like lobectomies or hemispherectomy, and or different parts of the brain again can be disconnected if they're generating one source of generating the seizures. And the new thing is that we are using some devices like RNS and DBS to stimulate the certain parts of the brain to stop the seizures. Next slide. So why, I was thinking about it, that's why I am here. So one motivation I have is the kind of, we have hit a ceiling where the number of surgeries have not kind of lived up to the par for us. They have not increased as we were expecting that they would come turn of the, after the 2000 and after the end of the 90s. We have hitting same number even in America, which is way advanced than the rest of the world. We are still hitting kind of ceiling. So according to the WHO survey in the world, there are between 50 to 60 patients per 100,000 population per year who have epilepsy. And that is for the developed countries. For the underdeveloped countries, the number is from 150 to 175 person per 100,000 per year. So that's a higher incidence. So if you look at that, our estimate is the NAEC, which is the National Association of Epilepsy Centers, it came up with the data in 2019 that there are approximately 100 to 200,000 patients who can be surgical candidates just in US. And if you look at the incidence, 50 to 60 per 100,000, so that makes around about 100,000 people every year who could be a candidate who can benefit from evaluation for epilepsy surgery. But we know that, as I was saying before, the important highlight is our ACMAG, which is American Clinical MEG Society, published data in 2020, and we found out that since 2000s, we are hitting a ceiling of between 3,500 to 4,000 people who have surgery every year. And this number has not increased, considering that there are almost 200,000 people who should be looked at a level 4 or level 3 center to see if they are surgical candidates. So why that? It's a very interesting quote, and it's very important, the evolution, how it has kind of changed. Dr. Sutherland was a very famous neurosurgeon, and he said that the entire progress of neurosurgery has parallel and dependent on increasingly sophisticated neuroimaging. So just to cap it up, what he's trying to say is, and what we'll talk more about is, that we have kind of evolved as our imaging tools have evolved, that we have become, more and more people have become candidate for epilepsy surgery. It used to be in late 90s that we used to do epilepsy surgery for patients who have a visible lesion or a tumor or dysplasia or CAV malformations on the brain, and if they had seizures and we feel the seizures are coming from that area, you take that out and their seizures got a lot better. So from that, in 2000, we have progressed to the point where we're looking at the patients which are, in simple words, you can say they are MRI negative patients. Their MRI looks normal, but there is a lesion in the brain which is generating the seizure. So we have started with the help of the new imaging tools, we have moved into the era where we are looking at functional imaging, and we'll talk a little bit more about it in coming slides. Next slide. So as I was saying, the pre-surgical evaluation have evolved. We have moved on. The trend in medicine is to move towards the procedures which are less invasive and have less risk. That's the bottom line. And so is the surgery. I think the surgery is still needed, but we are looking into ways to do surgeries which are less invasive. Patients have to be in the hospital for less period of time. They can go home. There is less morbidity associated with surgery rather than mortality. So when somebody is a candidate for epilepsy surgery, how do we go through it, and what people should expect, what can happen? So we have kind of labeled it as phase 1 and phase 2. So bottom line is, these are the patients who mostly has focal or generalized epilepsy, which has been refractory to 2 first-line seizure medications. That's the definition of refractory epilepsy. They need to have tried. And if that is the case, the recommendation from the AES and the NAEAC, which is National Association of Epilepsy Center, is that that person should consider being evaluated by a level 3 or level 4 epilepsy surgery center, which are present in our country. So when you come to that, what would you expect? One, we generally like to do a video EEG. We are all familiar probably with the EEG if you're sitting in this room. So we like to usually do 4 to 5 days of video EEG. And the reason is most of the center would end up taking the patients off the seizure medication because you want to capture a habitual seizure, what is the most common seizure this patient has, where it is coming from, how frequent are they, if it's generalized, if it's focal, if it's coming from right or left, and these answers, basic answers, come from that. Then MRI, and as I said, functional MRI is more, as I said, is the functional MRI is a glorified black and white picture of the brain. Basically, it's just, MRIs are just like your cameras. Every year it goes up on megapixel. So the megapixel for your MRI is Tesla. So they started with 0.5 Tesla. Now I've moved into 3, and some centers have 7 Tesla. And what it is, as you can see, with the cameras, as they went to high definition on the news, you can see all the wrinkles on people's faces. So same that small, minute changes as the power of the MRIs increase, you can see smaller abnormal changes which are called cortical dysplasias. They become more evident with the higher magnet MRIs. A PET scan basically looks at the function of the brain, and with the expectation that if the seizures are coming from one focus, that would be kind of like a sick part of the brain, so it will utilize glucose less than rest of the brain, and it will be what they call hypometabolic. That's how the PET helps us. SPECT is another which can pick up where the seizure starts from. MEG scan is a non-invasive tool which we use very frequently. It can do multiple things. It can lateralize the seizure. A lot of people have asked, if people are doing EEG, why MAG? So MAG is the magnetoencephalogram, which look at the magnetic activity of the brain. And magnetic activity does 2 things. What we call, it has a greater spatial and temporal resolution as compared to the EEG, meaning timing wise it gives real time information, And the localization of the MEG scan, which we'll talk a little bit later, is far greater than any other modality. So it really helps to pinpoint where the seizure focuses. And when the MEG scan is kind of gives you information, if you can localize a seizure to one place, the localization value of MEG scan is in millimeters, 1 to 5 millimeters. Accuracy is just awesome. So it can really add on. WADA test is kind of, we used to do WADA a lot. So with the functional MRI and with the MEG scan, the utility of MEG scan, of the WADA test has significantly gone down, because WADA test was an invasive test. So that's what I was alluding to before, that we are moving away from the invasive testing. Transcranial magnetic stimulation is another way of finding out where the seizures are coming from. We're also interested in the brain, finding out where the eloquent areas are. Eloquent areas in the brain are which generate speech, memory, motor function, sensory function. So the transcranial magnetic stimulation, MEG, and fMRI can help you localize. Neuropsychological testing gives us information for the hemispheric brain dominance. If the left hemisphere is dominant versus right, if the memory is in the left or right. So all these information then put together, you should have a level 4 epilepsy center has a board which is called epilepsy surgery board, where they have epileptologists, they can have neurologists, neurosurgeons, and neuropsychologists. So they all sit together and look at this data for every patient and then come up with proposition what would be the best next step would be the phase 2. So in phase 2 we used to put till 2010, we're putting a lot of subdural grids. What it was, we do a craniotomy, and they were just like EEG sheets. They were embedded in a plastic polythene kind of wrap, and you just stick them on top of the brain. The idea was the EEG electrodes are more on the surface. When you get closer to the brain, you get more information. In 70s and 80s, the French people came up with the idea that if we need more information, why not to have electrodes on a wire, and you put the wires in the brain and record from there, so you get real-time information inside the brain. So that's what the stereo EEG is. Cortical stimulation again is for the functional mapping, where you want to, before you do surgery, you need to know what part of the brain controls your sensory motor area, what part of your brain controls your speech, as well as the memory. So that's the functional mapping. And this is the quote we put in there just to memorize and to make sure that I mentioned that just make sure that if you have undergone an epilepsy surgery evaluation in 2008 or 9 or 5 years ago, 10 years ago, it's such an evolving field. If you were declared not a surgical candidate at that time, that does not mean that 5 years later, 10 years later, you would not be a surgical candidate. So recently, actually till last year, there were a couple of things which came up, like our surgical approach change. There were new tests which are available in last week or more. And that completely, the surgical kind of paradigm table that we as a doctor use to what to do has changed a lot too. So if you have been previously looked into, it's worth looking again. It's not something if somebody tells you that you are not a surgical candidate in 2010 or 12 or 15, one, not to get another second opinion or not to look again. There's no harm in looking again because you are dealing with it every day. It's a serious condition. Epilepsy has its long-term and short-term implications and complications.
All right. So this is where we get into the actual case study. So this is my daughter, Virginia, in her first year of epilepsy. She started having seizures at about 17 months. They just came out of the blue. One day I saw her do something and had no idea what it was, but then she did it a few more times, and then I finally realized I think she's having a seizure. So she suffered from focal onset aware seizures. They tended to happen in clusters. Sometimes a cluster was 2 or 3 in the morning. Sometimes a cluster was 60, and they were, every 8 minutes, 9 minutes we're having a seizure, but it didn't tend to be one seizure and then nothing. And she failed nearly a dozen drugs. Dr. Malik has already said now we've completely changed the way we think about this, and if someone's failed 2 drugs, we want to be talking about surgery, or at least talking about a surgical evaluation. Virginia was it was 2004 when she was first diagnosed, and we were not thinking that progressively about epilepsy surgery at that time. We tried the ketogenic diet as well, and she also failed that. So we were looking at everything. And to the point that Dr. Malik made on the last slide, we did pursue a surgical evaluation several times. So we'll talk a little bit about more about that too. But again, this is just a quick look at her seizure pattern. This image here is from an app that we used at one point to sort of record her seizures. So we're looking at 5 months of seizures. She had about 123 in that time, or those are the ones we wrote down anyway or recorded. She experienced both rigor and tremor. She didn't collapse. She would always just sort of find a place and slowly lower herself down, even as a baby. I remember finding her sitting on the stairs in our house, and I said, "What are you doing?" And she said, "I had a seizure. You're supposed to write it down." And then she would just get up and walk away. But she kind of could feel it coming most of the time and could get to a safe place, which is good because she was a competitive rock climber. But like one whole side of her face would twitch. She had some ictal spitting sometimes. That developed much later. In middle school she started doing that, which was new. So certain things changed over time, but there were other consistencies. So as I said, at its worst, it was 40 to 60 a day for about 4 months. And at the time we first visited Dr. Malik's team at Cook Children's, she was having about 10 a week. By that point, she was 17, and they were mostly occurring in the very early morning hours, starting as her body started to wake up, and she would have, again, about 10 a week. So over time, they became almost exclusively nocturnal. But what we knew for sure is the minute she forgot her medication, if she missed one dose or took it a few hours late, she would have seizures. So we never had complete seizure control, but we could tell the medication was making some difference. The problem was she literally couldn't remember to take it. And we would even test her. We would give it to her, let her start walking away, and it sounds mean, but we really wanted to see how much she could remember. And we would say, "Come back, you didn't take your medicine," and she would turn right back around. She had no idea that she had just taken it. Even though she was a really functional kid in many ways, her memory was just gone. And so as she started thinking about, moving on and moving out, which we all wanted, as you do with teenage kids, it just didn't look like it was going to be a possibility. So we wanted to mention getting a second opinion. Hopefully you all have been hearing this all along, and it's not that we don't trust the doctors we're seeing, but it's that, more minds looking at the same problem are looking at it from their own angles, through a different lens. So with Virginia, we got probably 11 different opinions. And ultimately, the second opinion we got about the surgery one was the one that made a difference. But when is it time to get a second opinion? So I said this yesterday, so if you've heard it already, but if you don't feel like your physician is treating you like a partner, it is time for a second opinion. If they belittle your concerns, if they don't take the time to explain things to you, get another doctor, get a second opinion. Anytime you're at an inflection point in treatment. So we went to Cook because the doctors at our own local level 4 epilepsy center said she's not a surgery candidate. They're coming from everywhere. And, again, watching her behavior, I was convinced they were coming from one spot. And again, she was going to turn 18 soon. She wanted to move out. It was a huge inflection point for our family. So I thought, you may be right, but I need another person to tell me you're right before I give up on this pipe dream of surgery. Again, if you have a big diagnosis and you want it confirmed, and then if your clinician or your hospital doesn't offer, the most advanced care, we're talking a lot during this conversation about MEG. Not every hospital has that. Not every hospital has a ton of experience doing the surgery you might look at. That's when it's time to get a second opinion. And, people have brought up like, well, I don't want to hurt my doctor's feelings, or how will my doctor feel about it? This is absolutely what your doctor would do for their child, right? You would get,
yes.
So it's what they would do for their kid. So anytime you're feeling like, do exactly what a doctor would do for their children and get a second opinion. All right. We're going to talk about some previous evaluations.
All right. So when we saw her, so she looking at her medical records, she had gone 2 major kind of evaluations at different centers. So in 2011, she had what we said before. She had gone long-term EEG, MRI, PET scan, a SPECT scan, and then again same evaluation with the SPECT scan, and then high-definition EEG, as well as She underwent an intracranial EEG, and it was the stereo EEG she underwent. We'll talk a little bit more about details about it, but she had an extensive testing done. But I think what was missing was the MEG scan. She never had a magnetoencephalography done. Next slide. Yeah.
I'm going to talk about this.
Yeah,
Okay.
sure.
So the other thing we've been hearing this week while we're here is that maybe a child has had or a patient has had an EEG, but they haven't had a high density EEG. So again, when we talk about the MEG and all these tests, they're all complementary. They're not replacing each other. You know, they all are bringing different data to the physicians and the researchers, and they, you know, take all that data and get a fuller picture. So as you can see here, that's Virginia on the left with an at-home EEG. We've got, you know, the 19 channels, and if you're looking at a high-density EEG, we're talking about 256 points of data. So still just on the scalp, but, you know, much more detailed image of what might be happening. And she didn't have that until a year before her surgery. So she did have an SEEG at her second surgical evaluation, so she's 16. So for those who don't know, with a stereo EEG, and I see that we've accidentally called it an IEEG in some places, they're actually interchangeable names. So if we're saying IEG or SEEG, we're talking about the same thing. But the electrodes, as Dr. Malik said, they drill tiny little holes in their skull and put these wires, very thin wires in. And so rather than trying to read through the hair, through the scalp, through the skull, you're going right into the soft tissues of the brain. So for Virginia's first stereo EEG, it was February 2020, 15 electrodes implanted, took her off her medicine, 3 days, the drill, you let all hell break loose. And so in 3 days, she had 18 seizures. So we felt like, okay, we're collecting, these are fact-finding missions, you're collecting data. So that's what we got on the first one.
Can I make a point on
this?
Yes.
This is not hers, right?
Yeah. So the stereo EEG we were talking about, this is a really good picture actually. So if you, most of you have seen the EEG, and it each has an electrode and the wire coming with it. And with the help of the glue, the electrode is put on the head in different parts of the head. So this is a wire. You're not seeing the wire. This is the stereo EEG, and what each dot represents is a very, very small electrode. And that electrode, minor electrode or small electrode, is connected with the wire, and they all together wire makes a thin thread. So when they put a small tube in the brain, and then there's this thread into it. So the recording, this dot, as you can see, represents a single kind of electrode of the EEG. So it's giving immense amount of information that you are getting real time from the brain coming to you. Sorry about that.
No, that's okay. No, that's super helpful. Yeah, this is not my daughter's SEEG, but we thought, again, great picture of one. So this is my daughter while she's got the SEEG in. So you are seeing how they're all over her head.
So here you can see that she has the electrode. One thing you can notice is that the things you're seeing on top of the head, these are anchors, and these are holding that wire, because that wire is so thin and agile that it is holding that wire in there. So as you can see in her, she had a bilateral implantation. We do bilateral implantation when on surface EEG, we are not sure if the seizures are coming from the right side of the brain or the left side of the brain. And so that's what she has. Another point I want to make, that people often, my patients would ask, that you are going to put this wire inside the brain, when you take out, does it leave a track or does it cause an injury to the brain? So these wires are so thin that when we take them out, we have done serial MRIs, and you can see them till 6 weeks out. But after that, if you do another MRI, they are completely gone. You cannot tell. The wires are so thin that you would not notice. So even we have put up to 30 stereo EEG electrodes on both sides of the brain, and you take them out and patient do fine. Because it's an invasive procedure, there's a risk of hemorrhage, infection, but extremely rare. It's very rare that this will happen. So they did that in Virginia case, and they captured the seizures they felt they could not lateralize, meaning could not tell if they are coming from right and left. And they recommended that she should have a DBS. So 2 points I want to make over here, that the stereo EEG are as good as your plan is. So if your plan is not that great, or if your theory where the seizures are coming from, you need to have, another way to put it is that stereo EEG is a test of hypothesis, and your test is as good as your doctor's hypothesis where the seizures are coming from. Like you can say, I think the seizures are coming from the frontal lobe and or temporal, so you can tell the stereo EEG can help. But if the other thing is, when you, as we're looking, when you put the stereo EEG electrodes in the brain, it gives you a lot more information than EEG. But other thing you have to keep in mind that you are basically looking inside the brain with a microscope. So what happens when you look with a microscope is that you are just getting a limited information about your field of the microscope. So if your electrode is not at the right place, you may not get the information. And if the seizure is starting somewhere else other than so it spreads quickly, so your electrodes may simultaneously pick the seizure coming from right and left, and you may feel that this is a generalized epilepsy, or you don't know which side the seizures are coming from. And if that happens, one way we deal with recently, which I mentioned, two modalities which have become more kind of acceptable. If either you're not sure where the seizures are coming from, if the seizure onset is multifocal, or if there's a generalized refractory epilepsy, that we consider DBS, where just electrodes like stereo EEG electrodes are put inside the deep in the brain, which is called the deep gray nucleus. So that's what it was recommended for Virginia, that since they thought it's either generalized epilepsy or she has a multifocal epilepsy, so she would be a candidate for DBS and not a resective surgery. So we got an opportunity to meet with her and her mother when they come to visit us, and basically we have to do this workup again. So we did all the testing, which has been, some of it had been done before, but we definitely included the MEG scan. Lucky enough to be part of a center which has a MEG scan, so it was big help. And plus, as well as we had our EEG, the high definition EEG, which we were able to do. So what happened was that with her MEG scan, so talking about the MEG scan, as I was alluding to a little while ago, that MEG scan, we have seen that sometimes people we often get asked that what if my EEG is normal, why would I do a MEG scan? So there is actually a good amount of published data that if the patients who have normal EEG, and if they have seizures, epilepsy, refractory epilepsy, so almost if you do MEG, another 30% of the patients who were not kind of deemed surgical candidate because of having a normal EEG can turn out to be a surgical candidate. Like her, she was a prime example. So in her case, we found a really tight cluster of dipoles. What dipoles are, I'm sure you guys have heard the spikes on the EEG, which tells you that this person has a tendency to have a seizure. So these spikes are basically selected. They are processed through the computers and through the software, and then we have a software in the MEG scan which can put these dipoles, what now the spikes after they're processed, they are called dipoles. These dipoles can be processed and they are superimposed or merged with the MRI. And as I said, the MEG has capability of merging these potentials of dipole with the MRI with an accuracy of 1 to 5 millimeters. It's really, you get a really decent and very accurate, what we call an excellent spatial resolution. If you get what is a cluster? So if you get a spike going back to a same area, more than 4 or 5 spikes in a recording, there's a high likelihood that that is what we call a seizure onset zone. So that's what we find in case of Virginia. So next slide. So I think I talked most of this MEG. Another point which I kind of not forgot to mention was that there's a the reason we went after the magnetic activity of the brain is that property-wise, we don't need to go in details about this, but property-wise, the big difference between magnetic activity versus electrical activity. EEG is the electrical activity. If you remember from your high school experiments in the class, the electricity intensity depends upon the medium resistance which it is going through. The higher the resistance become, the lower amplitude the electricity becomes. And the other issue is the electricity, if the resistance is significant, electricity can change its direction. So sometimes the patients who have a focal seizures coming from the right middle of the brain, that's kind of parasagittal area, the electrodes, because the way they are oriented and presence of the bone or any tumor or anything, the left-sided electrodes can pick higher activity as compared to right. So that can create a right-left confusion. As compared to that, the magnetic activity, not only that, it is not affected by the medium it traverses, it also does not change its direction. So you get same, if it's coming from left, you're going to pick it up from the, so those are the highlights. The only issue is with the MEG scan that actually the magnetic activity is generated secondary to the electrical activity. So what we call the amplitude of the magnetic activity is extremely small. To give you an example, in the heart you are talking about millivolts, the EKG, the EEG is microvolts, but the magnetic activity of the brain is the unit we use. We just talk about the Tesla with the MRI, 1 Tesla, 3 Tesla. So for magnetic activity, the unit we use is 10 raised to power minus 15 femtosla. It is extremely low. I'm like, another simple way to explain would be, I like to explain is, it's like you're trying to record a pin drop noise in the rock concert and you're sitting in the front seat. So what we need is, we need a room with the 0 decibel noise, with no noise. How do we do that? So we have shielded rooms. They are specialized room where we monitor this, and we have specialized system. This is a really good example of that. And the patient sits in there. I think the important point I want to make it is that it doesn't look like, but actually the patient has just the EEG electrodes on their head. But there is no contact between the machine and the person. So person just, it looks like an old hair dryer kind of a thing, but there is no contact. It's just that the patient head needs to be inside there, almost like a helmet, but there is no touch. The patient has to just sit in there. That's where I was saying that it's so non-invasive. There is no contact. The electrodes patient has in the picture, they are for the EEG recording, because we like to simultaneously record EEG and MAG. So that's a really good thing about MAG. That is, the recording is just very, very non-invasive. Next slide. So that is her MAG scan, and as I was describing, this is the MRI basically, which is fused. The fusion process is called magnetic source imaging. So as you can see here, there's a huge, what I can call a tight cluster of dipoles in her brain, in anterior part, what we can call as in her right insula. This MRI is flipped, that's why, because of the software, generally they are other way around. But anyway, this is her right side, and there's a tight cluster of dipoles. The other important thing I want to make from her MRI, and we have seen this quite commonly, that when people can have a normal MRI, and then when you do a MAG and you see a cluster, now we usually go back and take the MAG spikes out and then look at this portion, really you stare at it for a few minutes and you would start seeing that there is some abnormality down there. So that happened with her case. A lot of people had looked at her MRI, including us. We had looked at her MRI too, and we could not see that there was anything wrong with it. MRI looked normal. But when you do the MAG, now if you take the kind of scrub away these dipole cluster from there, we saw that there was very, very faint, what we call a gray-white blurring, and that's kind of sign of a subtle cortical dysplasia. So we really felt confident it was kind of that she has a seizure focus which is coming from, and just because of the location, and the insular seizures are more kind of they can have a diverse presentation, and they can spread because it's if you look, it's close to the midline, and that's why if the electrodes on the scalp, like EEG electrodes, or if they're even deeper, if they're not close, they can pick up this activity simultaneously, and I think that's what was happening for her.
We probably covered most of it, yeah.
Yeah, we covered most of it. It's just inside. Yeah, one thing I didn't cover, I wanted to mention. So, what is inside what we call this long thing which says MEG trio? This is called DIOR, and what it has the superconducting quantum interference devices, which are squids. These are electrodes which are recording the activity almost like EEG. But the issue is because the magnetic activity is so small, so these electrodes or squids are immersed in helium. So the helium takes these squids' temperature to minus 256 Celsius. So they become superconductors. So that's why everything is immersed in this DIOR and separated for patient head. Nothing touches the patient head. So just to make everything what I said was clear, does the MAG replaces other tests? It does not replaces it. It's every test we talk about, we still do them. They all complement each other. The EEG is still very necessary, as is the MAG scan. And you have to look at the whole picture. Since we are talking about brain surgery, you want to have as much information as possible. The more information, in my personal opinion, the more information better, because it can help me make better decisions. And as Dr. Sutherland said, the neurosurgeon said a year ago, and I still believe that I've seen the more advancement we have in the imaging and functional imaging, we are becoming more safe in performing surgery, and we have been able to help more patients. So that was the same case with Virginia as well. This is the MAG scans which have been put in by MAGin people. There are 19 total sites. I was looking at it. The data put out by the AC MAG, which is American Clinical MAG Society. When they put out the data, they found out that there were 256 epilepsy monitoring units in the country, level 3 and level 4. And they said that 30% of those had MAG scans. So I think all MAG centers are not equal, certain percentage have it. So I would assume by that number, I think I don't have the exact number, but I would assume 60 to 70, there are 70 centers in the country, in US, which are using MAG scan as part of their investigational workup. And there were a lot of centers which would send patients to get MAG scans somewhere else. Next slide.
Okay.
So
Dr. Malik described Virginia going to Cook Children's for her very first visit, where they repeated a few things and they did the MEG scan. And that was what was incredibly new for her. That was the game changer. So what we were told by Dr. Perry, her epileptologist, was we were certain where it is, and now we need to be pinpoint certain. So he had to call with the not perfect news that we were going to have to repeat the SEEG. You remember that picture where we were showing them sort of all over her head? Well, look in that spot right there where those little marks are. That's where we didn't have good coverage. And it was clear to the Cook's team that that's exactly where it was. But we had to be pinpoint certain of the spot. So a much lesser surgery, but repeating the SEEG. And we, again, take her off the medicine. We're only looking at 9 electrodes now. Take her off the medicine, let her seize for 5 days, and she had 9 seizures. But what Cook was able to tell us before they even went back into the OR to take the electrodes out, they said, we know where it is. We know how big it is. So they said, it's discrete enough, it's small enough, and because of its location, we can actually do what is called a laser ablation. So using the heat of lasers to destroy these 2 very small spots in her brain. So very different experience than our first SEEG. But just so people have so many questions about SEEG, these are little tiny tiny little stitches that she has on the side here, and within a few days you couldn't even really see them anymore. From a comfort level, it's a little tricky to use their jaw and to eat, and there are some headaches involved, but that's kind of the extent of what she felt. So anyway, a great experience, and before she even goes back in the OR, they say, we're going to go ahead and do this. And the other interesting thing is when she was in the OR, we were talking about this last night, I think, when she was in the OR waiting to go in for her second SEEG, she was just sort of looking at her phone like we all do, and she got her first college acceptance while she was in the OR, and everybody erupted, and it was just sort of this full circle moment of this is why we're doing this, so you can actually move away from home and do what you want to do. So a quick thing about laser ablation, and we're running short on time, so we probably need to do highlights at this point.
Okay, so very quickly, laser interstitial thermal ablation is a specialized procedure which is done with an iMRI. MRI is present in the OR, and basically what we're doing, just like stereo EEG, you put the electrode in. This electrode can select certain area. I think that 6 centimeter square meter is as far as it can kind of does the thermal ablation. So if the lesion is bigger than that, then you have to do surgery. But the great thing is for the lid, you do not need craniotomy or open the skull. Lid is so quick that patient can come in one day, get a pre-op, get the surgery done. It takes 5 or 6 hours because we have to do MRI once or twice in between. And then overnight patient stays in the ICU, gets a dose of a couple of steroids, next day patient goes home. So it's an extremely quick way to do it. And when you have identified the lesion right and everything sets right, the patient can become seizure free within 24 hours without any craniotomy scar. I think that.
Yeah, and this is an actual video, but we can't play it in here because there's no Wi-Fi. So if anyone wants to see the video, this is her surgery actually. It's probably totally illegal that I have it. But if you want to see it, I'll show it to you because the cat's out of the bag. So a quick word about level 4 epilepsy centers, and I'm not going to hound on this too much because you've heard it from me and others over and over, but they're not all created equal. So you just heard about an experience, 2 different SEEGs at 2 different level 4 centers. So just keep that in mind. They even though they have the same, for lack of a better phrase, certification, they might be very, very different, and that was certainly our experience. And part of what I should have done probably a little bit more of the first time was, these questions that have come up in several sessions. How many times have you done this exact procedure? How long has it been performed at this hospital? What are the risks and potential complications of this seizure? What will the recovery be like? And what is the probability of seizure freedom after this procedure? These are just some of the questions. For those who are interested, the Pediatric Epilepsy Surgery Alliance has a much more comprehensive list on their website. They're here today, and they kind of give you all the reference materials you need to sort of start the surgical evaluation. So Dr. Malik talked about the recovery. Virginia had this surgery on December 2nd, 2020. She was discharged from the hospital on December 3rd, 2020. We flew back home from Texas to Virginia on December 4th. And she's never had another seizure. And it was the quickest surgery. I always joke, she had 2 tiny stitches here, and I said we've had more stitches after a birthday party than we had from this seizure. It was just nothing. She did get bangs to cover up some of the other stuff while it was all healing. She returned to school the following week, returned to rock climbing a week later, wasn't supposed to, but we were all kind of losing our mind. And then she took the ACT a week later, which was not my plan. I'm a terrible mother who believes in benign neglect, and I had no idea she was taking it. And she said the Friday night before, we've been home literally a week, she said, I need a ride tomorrow, I'm taking the ACT. And I said, oh sweetie, you've already taken it twice, you got the same score both times, you did fine. And she said, no, she wanted to get a certain score and she hadn't gotten it. Well, 1 week after brain surgery, just like the Tesla scale, the ACT scale is exponential. So going up a point is actually quite a big deal. She went up 4 points just after having brain surgery. And when I talked to her team at Cook, they said, she was having little tiny interruptions, little tiny seizures all the time. And it's not all sweetness and light. Obviously my child has brain damage. She missed out on a lot socially. We can't fix some of that stuff. But it was very clear to me that she could function at a much higher level for her, which was always our intent, right? Whatever your potential is, how can we help you live up to that potential? So she had some headaches and she was tired, but she slept through the night. And I don't think she had ever slept through the night. Probably hadn't slept through the night in about 10 years. I slept like a dead person for weeks because my body just finally could sleep without having to worry about seizures. So it was a very simple recovery. Today, like I said, it's 23 months and counting. She's never had another seizure. That doesn't mean they couldn't come back, but so far so good. She's a college freshman. This is a picture of her with my husband when they were visiting colleges, and then that's her on the right at Parents Weekend recently. So she's having a great time and being a regular college kid, doesn't have to explain it to everybody, doesn't have to worry about bothering roommates with nocturnal seizures, and she lives independently, which we never thought would be possible because she's not dependent on our drugs anymore. So again, it's not all sweetness and light. We've had plenty of other issues as well, but so much more potential than we imagined for 16 years. And you get the final say.
All right. So I think we reiterated, most of these highlighted points. So I think the people should really need to consider, and we need patients to educate for themselves that have, if you have failed 2 seizure medications, you need to ask your doctor if am I a surgical candidate. That's kind of a bottleneck for us. I cannot go out and get patients to come to my center. And the patients have to go through, unfortunately, outside, maybe not that much neurologists, but there are a lot of other specialties or primary care who take care of patients who have epilepsy, who are still on medications like Dilantin. They need to have their patients evaluated. And the other point we already made that, if you had an evaluation done a few years ago, there's no harm in revisiting. And there is always a hope. Never give up. The story may not be as good as it is, but there is always something to do and to try, and never give up is, I think, the basic message.
Great. So we've got a few minutes. We're happy to answer questions. We've got a small group, so feel free to ask. And I would also say, if there's something you don't want to ask in front of a large group, you can come to the MEG table afterwards to speak to us individually. But is there anything that anybody wants to follow up on or ask about based on what we just did? Yes?
It's a titanium plate? I think you should be fine. We would need more information on the titanium plate, but if it's not magnetic, like if it's not, most of them are not, if you can get it. Yeah, we need more information on it. But did you had MRI after that? Ever? And then they were fine doing the MRI? It was fine. So I'm pretty much sure then you would be fine too. Yeah. And where is it? Like where is the titanium? Like what part of the head? On the left. Yeah. So sometimes we need more information, and we can, whosoever does the MAG, they can run the information to figure out where that came from and if it is ferromagnetic or not, so that information can be obtained.
But if it is magnetic, would it?
Say it again.
But if it has some sort of magnetic component, then it would interfere.
If it is magnetic, then it will. Yeah. If it is metal in it, it will. The same thing as with the cochlear implants, because if they have a magnet in them, then it becomes an issue.
Anything else? All right. Well, thank you all so much.
Awesome.
Like I said, if you want to come up to us after, if anyone wants to see the video of the lasers doing their thing, I'm happy to show you too.